Good morning. Today we will start with the pathologies of the orbit. The main pathologies which we will cover in our syllabus for the new final are the first one is the orbital cellulitis. What is orbital cellulitis? What is orbital cellulitis? Orbital cellulitis can be divided into preceptal and postseptal. Orbital cellulitis is a purulent inflammation of the cellular tissues of the orbit, that is the soft tissues of the orbit including the muscles. What is a preceptal cellulitis? See, the orbit is divided into two parts by the orbital septum, which starts from the rim of the orbit. The part of the eyelids and all those structures which are interior to the orbital septum, the inflammation of those parts leads to preseptal cellulitis, and the part beyond the orbital septum, the inflammation of this part leads to orbital cellulitis. The preseptal cellulitis is caused, the preseptal cellulitis, that is the part interior to the orbital septum, it is caused by the continuous spread of infection from the local facial or the eyelid injuries, insect or animal bites, conjunctivitis, chalazion or sinusitis. The orbital cellulitis, that is the inflammation posterior to the orbital septum, is caused by the extension of infection from the adjoining parts such as the nasal sinuses, lips, teeth, face, penetrating injury of the eye, infection after the ocular surgery, spread of infection from the other parts of the body, and a common differential to the orbital cellulitis is metastasis or tumor, especially in the patients having a systemic or non-Hodgkin's lymphoma. What are the pathogens responsible for the orbital cellulitis? These vary by etiology and the patient's age. Streptococcus pneumoniae is the most frequent pathogen associated with the paranasal sinus infections. Staph aureus and Staph pyogenes infection arises from any local trauma to the periorbital region. Haemophilus influenza type B is less common nowadays because of the widespread vaccination for the same. Fungi are the uncommon pathogens causing orbital cellulitis in diabetic or the immunosuppressed patients, and the most common fungi is Mucor or Mucor rhizopus aspergillus in the diabetic patients. Infection in children less than 9 years. A single aerobic organism is mostly responsible. In the patients having orbital in the patients more than 15 years having orbital cellulitis, polymicrobial infection is the suspicion with aerobic and anaerobic bacteria like bacteroids and Peptostreptococcus. The pathophysiology can be divided into various stages. This can be used as even as a clinical classification to tell about the prognosis and the treatment. The stage 1 of this modified Chandler staging system is the preseptal cellulitis, that is the inflammation of the tissue interior to the orbital septum. The next stage is the diffuse cellulitis, that is the stage 2 has the inflammation of all of the orbit including the preseptal and the orbital area. The stage 3 is the subperiosteal abscess. The subperiosteal abscess is the abscess between the bone and the periosteum. Stage 4 is the orbital abscess in which the pus collects between the intraconal area, and the stage 5 is when this orbital inflammation spreads to the cavernous sinus and leads to the cavernous sinus thrombosis. Thus we can label stage 5 cavernous sinus thrombosis as being a part of orbital cellulitis if it develops after the features of orbital cellulitis. Complications of the orbital cellulitis are vision loss, which occurs in 3 to 11%, and this is due to the ischemic retinopathy and the optic neuropathy caused by the increased intraorbital pressure. This increased intraorbital pressure will put the pressure on the vessels and the nerves supplying the eyeball. That's why there will be the vision loss. There will be restricted ocular movements, that is ophthalmoplegia, caused by the soft tissue inflammation, and the intracranial sequelae can be resulted from the central spread of infection, including cavernous sinus thrombosis, meningitis, and the cerebral abscess. What are the symptoms of the orbital cellulitis? The eyelid and the surrounding soft tissue will have the swelling and the redness. There will be severe pain which increases on the eye movements or pressure, which is due to the extraocular muscle inflammation. What are the associated symptoms? There will be fever, which is present in the orbital cellulitis, and it is seldom present in preceptal cellulitis. There will be nausea, vomiting, prostration. Decreased visual acuity will be there, and rarely there will be a loss of vision. Vision is not affected in the preceptal cellulitis, but is decreased in orbital cellulitis. Periodontal pain and swelling with abscess, headache and lethargy if it is present. Always suspect associated meningitis. What are the signs which we see in the orbital cellulitis? There will be marked swelling of the lids, body hardness and redness will be present of the lids. There will be marked chemosis of the conjunctiva which protrudes and becomes desiccated and necrotic. The eyeball as a whole will be proptosed axially, and there will be no proptosis seen in preceptal, but this is a differentiating feature between the preceptal and the orbital cellulitis, that eyeball will be proptosed axially in orbital cellulitis. There will be restriction of extraocular movements, mild to severe, in orbital cellulitis, but this is not seen in preceptal cellulitis. On fundus examination, congestion of the retinal veins can be seen, and there will be the signs of papillitis or papillodoma due to the increased intracranial pressure. Diagnosis of orbital cellulitis is mainly from the clinical evaluation. CT or MRI, if possible, can be done. The differential diagnosis of the orbital cellulitis would be trauma, insect or animal bite without cellulitis, retained foreign bodies, allergic reactions, tumors, inflammatory orbital pseudotumor. The presence of a local nidus of infection on the skin makes preceptal cellulitis even more likely and not the orbital cellulitis. Okay. If the findings are equivocal, or on CT, if the findings are equivocal, or if the examination is difficult as in young children, or if the nasal discharge is present suggesting sinusitis, CT or MRI has to be done to exclude orbital cellulitis tumor or a pseudotumor in case of preceptal cellulitis. MRI, in the investigations, the MRI is better than the CT if the cavernous sinus thrombosis is being considered. The proptosis, that is the bulging of the eyeballs, the direction of the proptosis may be a clue to the site of the infection. For example, the extension from the frontal sinus pushes the globe down and out, outside, down and out, and the extension from the ethmoid sinuses pushes the globe laterally and out. Blood cultures are often done, ideally before the beginning of the antibiotics in the patients with orbital cellulitis, but less than only 1/3 are positive. Lumbar puncture is done if meningitis is suspected. Cultures of the paranasal sinus fluid are done if the sinusitis is the suspected source. Other laboratory tests are not particularly helpful. What is the treatment of the preceptal cellulitis? The initial therapy should be directed against the sinusitis pathogens, that is the paranasal sinus infections, that is the streptococcus pneumoniae, non-typeable Haemophilus influenzae, Staph aureus, Moraxella catarrhalis. However, in the areas where MRSA infection is prevalent, clinicians should add appropriate antibiotics, for example clindamycin, trimethoprim sulfamethoxazole, or doxycycline for the oral treatment, and vancomycin in the inpatients. Okay, vancomycin is always given an injection in IPD, in the inpatient wards. In the patient with dirty wounds, gram-negative infection must be considered. Okay, you remember this thing, gram-negative gram-negative treatment has to be given if the patient presents with dirty wounds along with the orbital preceptal cellulitis. The out treatment in the outpatient treatment, the options include amoxicillin and clavulanate capsules. For the inpatient, ampicillin or sublactam has to be given. The treatment of orbital cellulitis should be hospitalized. Patient should be hospitalized and treated with meningitis dose antibiotics. A second or third generation cephalosporin such as cefotaxime has to be given for 14 days and is an option when sinusitis is present. Imipenem, ceftriaxone and piperacillin tazobactam can also be given, but with the medicine consult. If cellulitis is related to the trauma or the foreign body, treatment should cover gram-positive including MRSA if it is in the prevalent area. And what is the dose for the MRSA? It is vancomycin 1 gram IV every 12 hours, and gram-negative also has to be covered. What we have to given to cover the gram-negative? Ertapenem 100 milligram IV once a day, and this is to be taken for 7 to 10 days or until the clinical improvement is seen. When do we do surgery in orbital cellulitis? Surgery is done in the orbital cellulitis to decompress the orbit, drain an abscess, open infected sinuses, or a combination is indicated in any of the following circumstances when the vision is compromised, suppuration of the foreign body suspected, imaging shows orbital or large subperiosteal abscess, particularly along the orbital roof. The infection does not resolve with antibiotics. At this juncture, surgery can be done in cases of orbital cellulitis. We will continue with the cavernous sinus thrombosis in the next video.